that we got this Amos Best Society Award trophy. So I welcome you all for the PG Star series organized by Nagpur Obija Society with Government Medical College, Gondia. Thank you, Dr. Rajesh Patil. Friends, this is our 20th PG webinar series. And we always want all positive things in our life. And when it comes to our profession, that only positive, we think about only positive and positive. But when a patient is born with some negative things, that is Rh negative, that too it is in pregnancy, then what to do? So today we'll be discussing Rh negative pregnancy. Dr. Vivek Gede ventured to deal with Rh negative pregnant lady to make the things positive for her. And so we are having two affectionate and academic faculties who will help Dr. Vivek to make all the negative, positive things. Welcome examiners, Dr. Sulbha Joshi and Dr. Shashi Kabra. Now we know that the ultrasound is one of the important factor to detect and making us alert about the negative activities going on in the uterus. So we invited Dr. Josna Rani Panigra to guide us on ultrasound monitoring of Rh negative pregnancy. She will enrich us with pearls of wisdom. Welcome, Dr. Josna Rani Panigra. Now we are blessed to have two more very positive and brilliant personalities to chair this session. Welcome, Dr. Rajesh Patil and Dr. Monica Singh. Dr. Neelam Sahani will put us in comfort zone for watching this negative to positive effect by weaving all faculties together. I must mention the positive faculties of this PG activity, Dr. Anuja Bhalerao, Dr. Bhakti Gujar, and Dr. Prachi Dikshit. Our secretary, Dr. Pragati Khadkar, is always there with us to make all positive things. So let's enjoy this CME. Thank you.
Our examiners for first session are Dr. Sulbha Joshi ma'am. She is the director, MUHS Fetal Medicine Fellowship Course, Umarji Hospital, Pune. Retired professor and HOD, OBGY, NKP SIMS Nagpur, past president, IMS Nagpur chapter, past president, IIPTB Nagpur chapter, BPNI, past secretary, Narchi Nagpur, instructor, ALSO, course of AAFP, run Mano Marriage and Bureau for mentally and physically handicapped. Our other examiner is Dr. Shashi L. Kabra, Maheshwari Madam. She's MD, FICOG, FMAS, DIP, MAS, Senior Specialist, Department of OBG, DDU Hospital, Delhi Health Services, immediate past chairperson, PCPNDT Committee, West District, Delhi, Secretary, Delhi Chapter, North India Gynec Forum Chairperson, Safe Motherhood Committee, AOGD 2024-26.
I think we can move on, madam. Thank you so much.
Now I would like to welcome Dr. Vivek Gede, here SMC Gondia, to present the case of Rh negative pregnancy.
Good evening, everyone. Myself, Dr. Vivek Gede from GMC Gondia. I am here presenting Rh negative pregnancy case in front of you. Hope I am audible to everyone.
Yes. Please go ahead.
Thank you, ma'am. My patient was a 30-year-old Hindu housewife, resident of Bantula. Husband was laborer by occupation, Halbi by caste, married since 5 years of non-consanguineous marriage, and she was Gravida 2, Para 1, Live 1, previous NVD at 9 months of amenorrhea and 40 weeks by, and she visited first time in our hospital, admitted from OPD for safe confinement with Rh negative pregnancy. On admission, there was no complaint of bleeding PV or leaking PV, no complaint of pain in abdomen, no history of epigastric pain, headache or blurring of vision, no history of trauma to abdomen, no history of any diagnostic procedure done. Patient pursues fetal movement well. On menstrual history, her LMP was the 4th of March 2023, and by Neglis formula, her EDD was 11th of December 2023. On admission and by scan of 10 weeks, she is 40 weeks, and period of amenorrhea was 40 weeks. She attended her menarche on 13 years of age. Her regular previous menstrual cycle was regular menstrual flow of 28 to 30 days, bleeding for 3 to 4 days, and 2 to 3 pads soakage per day, without passage of any clots and not associated with the dysmenorrhea. Obstetric history: she is Gravida 2, Para 1, Live 1, married since 5 years. On para 1 she had a male child, full-term normal vaginal delivery, 2.5 years of age, birth weight was 2.6 kg. He received, there was no history of any hypertension, diabetes mellitus, or blood transfusion. Baby was O positive, NTD received in the antenatal period and the postnatal period. No history of jaundice in baby and no history of blood transfusion in baby.
What was
Gravidity 2 is
mother's
present
blood group,
pregnancy,
doctor?
conceived.
What was mother's
Her
blood group, Dr. Vivek?
A negative blood group was
Okay.
there, ma'am.
Okay. Okay, carry on.
History of present pregnancy. In first trimester, patient was diagnosed by urine pregnancy test done at home. Patient was admitted in second month of ANC at private clinic with 2 months of amenorrhea and with history of spotting per vaginum since 1 to 2 days. NTD of 300 microgram was received. On first scan, she had done in second month, suggestive of single intrauterine fetus of 10 weeks of gestation. Routine blood administration done, and the blood group was of the patient was found to be A negative. Husband blood group was done, which was O positive. Indirect test was done, which came negative. Patient has taken folic acid supplementation. No NTNB scan one was done at that time. In second trimester, she received booster dose of injection tetanus. Anomaly scan was done at 20th weeks, which came normal. Patient took iron and calcium supplementation regularly. Quickening failed at 5 months of amenorrhea in her ANC period. In third trimester, she visited twice to the clinic. Iron folic acid taken regularly. Growth scan was reported normal with Leica adequate and with normal baby weight. Indirect Coombs test was done at 12th week, repeated at 28th and the 36th of week, which came negative. In past history, there was no history of blood transfusion in the past. There was no history of hypertension, diabetes, TB, or surgery in the past, or thalassemia. Family history was not significant. Personal history was normal bowel and bladder habit and sleep and appetite. On general examination, she was moderately built, well nourished, afebrile. Pulse was 92 beats per minute, normal volume, and the regular. BP was 110/60 mm of Hg in left arm supine position. Respiratory rate was found to be 18 per minute. There was no pallor, no icterus, no cyanosis, no clubbing, no edema, no lymphadenopathy. Tongue was moist, teeth, gum, tonsils were normal. Pre-pregnancy BMI was 23 kg per meter square. Total weight gain in the pregnancy is 10 kg. Breast examination was bilateral base was normal. On systemic examination in cardiovascular system, there was no abnormality detected. In the respiratory system, there was no abnormality was detected. On obstetric examination, for abdominal examination inspection, I found abdomen longitudinally ovoid, full term with flank full with healthy skin, umbilicus central and everted. There was no scar, stria gravidarum was present, and the linea nigra was present. On palpation, uterus was full term with full flanks. Symphysis fundal height was 34 centimeters. For performing all obstetric grips, the fetus was in the longitudinal line with cephalic presentation, head fixed, 2 feet palpable with fetal back on left side, with fetal weight 2.7 kg with adequate liquor and with no uterine activity at present. On perspecular examination, there was no bleeding or no leaking PV. Cervix vagina was healthy, no vaginal discharge. On per vaginal examination, modified Bishop score was 4. Her investigation done on admission, hemogram was 11 gram HB, 8,500 was her WBC count, and 256,000 was her platelets. Blood group was A negative, HIV, HBsAg, sickling, and VDRL came negative. Her serum TSH was normal 1.8, and her OGCT was normal 98. USG done on the 1st of December, suggestive of single intrauterine fetus of gestation.
Written, hello, excuse me. You have
Yes, ma'am.
written her EDT is December 23.
Yes,
and
sir.
you are mentioning USG date on 1st December 2024.
That wasn't typing, Mr. Ma'am, sorry.
Okay, it should be 23, I think. Then
Yes, ma'am. That 23. It was 23, ma'am.
okay.
Single live intrauterine fetus of gestation is 37 plus 4 weeks. Effective fetal weight was 2.5 kg. Placenta was posterior and like was adequate. My diagnosis is 30-year-old Niada2 para1 live one with 40 weeks of gestational age with single live intrauterine fetus with cephalic presentation with RH negative pregnancy without ISO immunization for safe confinement.
So what was the EDT of your patient? It's okay. Carry on.
Hello, ma'am.
Yes, carry on.
So it was 10th of December, ma'am.
Okay. So you induced and she delivered, right?
Sorry, ma'am.
Yeah, carry on, carry on.
So on management, patient was induced at 40 weeks with dinoprostone gel because her biceps score was 4. Patient delivered vaginally after 12 hours of induction. Outcome was the female child with birth weight of 2.7 kg. Baby was cried immediately after birth. Baby group was blood group was O positive. Mother received anti-D within 12 hours of delivery. There was no sign of jaundice seen in the postnatal period of baby.
So, yeah. So you have
Doctor,
mentioned here,
carry on, madam.
yeah. So you have mentioned here isoimmunization. So Dr. Vivek, please tell me what is the difference between isoimmunization and alloimmunization?
They both are the same terms, man. Previously, it was used as isoimmunization. Nowadays, it is used as alloimmunization.
What actually happens?
Actually, in isoimmunization, there is a there was antibody production against the antigen of the in the individual of the same species from the in response to antigen of the individual in the same species.
No, it is with respect to what? The antigen which is not present in that individual.
Yes, ma'am.
Yeah. Ma'am, you can ask.
Dr. Hema, your case was very uncomplicated. Patient came to you right from beginning?
No, ma'am. Actually, my patient was a booked case at PSC, ma'am. She came first time at my hospital for the safe confinement on the 40th week as the PSC doctor on the PSC referred her to the higher center, ma'am.
Okay. So, but this patient was aware that she is Rh negative.
Yes, ma'am. She was aware about her Rh negative status, ma'am.
Rh status.
Yes, ma'am.
And so, what is the protocol? What is normal protocol in a Rh negative pregnancy if the patient is pregnant for the first time?
Ma'am, when patient is pregnant for the first time and she visited to the any healthcare facility on the first time, we need to, if she doesn't know her blood group, then we need to do her ABO blood group and the Rh blood typing. If she comes negative, then at that time we need to also do the blood grouping of her husband to know whether her husband's blood group positive or negative. Right after
Yes,
that,
the first
if we
thing
come to
is you
know
have
that
to
her
do the
husband,
blood group of husband.
That's very
If
important.
husband
yes,
is
ma'am.
negative, then
we need to carry this pregnancy as normal ANC, ma'am. There is no need to intervene by any means.
and
Yeah,
if husband
perfect.
is positive, then
If husband is positive, ma'am, then we need to do ICT. If ICT comes positive, ma'am, if ICT comes negative, then we need to do ICT on the 20th week
suppose
and the
can
30th.
a patient who is pregnant for the first time have positive ICT? Is there a possibility?
Yes, ma'am.
In which cases?
If there is ma'am, there is a grandmother theory by
No,
which
no,
we
no,
can,
no, no.
there is
Okay,
No.
one is grandmother theory is one thing, one aspect.
There's
What are the other
some more
possibilities?
common reason, other possibilities.
It's very, very rare. We have not seen.
Yeah, it is
It was
very
your
rare.
theoretical.
sensitization also
Yeah,
occurs in the
exactly.
early pregnancy, ma'am.
No, if there is any history of
She
blood
is pregnant for
transfusion,
the first time and coming to you for the
Yes, ma'am.
first visit, you found that this ICT is positive. What is the possibility? Is there any other possibility?
Ma'am, there might be history of blood transfusion, ma'am.
yes.
That is one thing. Second, any other possibility?
Uh, she might had history of abortion, previous abortions, ma'am.
Which might have gone
Which
unrecognized.
might have been missed. It could be chemical pregnancy also.
So
there was her mother's blood group was A negative and husband's O positive. So is there any relation of ABO incompatibility with the degree of isoimmunization?
Yes, ma'am. If ABO blood is, incompatibility was there, then there is a less chances of the affection, ma'am. There is only 2% chances that in ABO incompatibility, affection is
Why this
very less.
happens?
Because,
What is
ma'am,
the reason behind this?
antibody present against the antibody present in the mother's blood group will destroy the very early if the fetal red cells will transfuse to the mother's body, ma'am, and
Yeah,
then that lead to the destruction of the whole RBC which are in the blood group, and that leads to the again the RH positive antigen will also destroy. Then there will be no antigenic response to the in the patient, ma'am.
So can you tell
Sometimes
me
we get many patients. We get patients for hysterectomy. We used to get a number of patients for hysterectomy. Patient used to be 5, 6 para. And at the time, at the time of hysterectomy, when we used to do her blood grouping, it used to turn out as negative. That means, and all other previous pregnancies used to be normal, with normal outcome. So how can you explain this?
Ma'am, in this case, ma'am, husband blood group might be negative blood group,
Okay. Yes.
or patient must be a non-responder to the antigen RH antigen. There are 30% chances that a patient might be a non-responder to the RH antigen, and there are again chances of the this fetal hemorrhage.
Yes.
So, Dr. Vivek, you have done ICT of the patient at 20 weeks and ICT is negative. So, what will you do further? Suppose it is a primary gravida.
Ma'am, I will do again repeat ICT on the 20th week of the gestation, and then I will give immunoprophylaxis, antenatal immunoprophylaxis to the patient.
When?
And again, I will repeat ICT at the 36 weeks of gestation, ma'am.
No, what is the time of giving anti prophylaxis? What week?
Sorry, ma'am.
When will you give the anti prophylaxis in antenatal period? Not 36 weeks. What is the standard guideline of FOXI and ACOG guideline?
Ma'am, I will administer NTD prophylaxis 28 weeks, single dose 300 micrograms.
Yes, if it is negative, I will repeat ICT every 4 weeks. And if it is negative by 28 weeks, then I will give anti-D gamma globulin, right? This should
Yes,
be the
ma'am.
answer.
Why
Okay.
28 weeks? Why this particular figure 28 weeks? Why not
Ma'am,
at 34 weeks, 36 weeks, 20 weeks? Because
ma'am,
fetal-maternal hemorrhage continues throughout pregnancy, isn't it?
there are less chances of fetal-maternal hemorrhage before the 28 weeks of gestation, ma'am. And the anti-D is effective till the 12 weeks, ma'am. So if we give anti-immunoglobulin at 28 weeks, that will cover till the 40th week of gestation. That will cover any fetal-maternal hemorrhage after in between.
One query, your patient had bleeding in first trimester and she had received anti-D, isn't it? Supposing
ma'am.
this patient bleeds again after 15 days, will you give another anti-D?
No, ma'am. If she bleeds after 3 weeks, then I will repeat the dose. But if she bleeds before 3 weeks, there is no need to give anti-D, ma'am. As the
3 weeks or 6 weeks?
Ma'am, actually 3 weeks FOXI guidelines says, ma'am, 3 weeks. Because median half-life of median half-life of anti-D is 26 days, ma'am. That will cover the 21 days or approximately. The FOXI guidelines
So if
says
patient
that
continues to have bleeding off and on, then how frequently
Is there
will
any
you give
method of
anti-D?
calculating fetal-maternal hemorrhage?
yes, ma'am. There are two methods. There are two types of methods, ma'am: quantitative and the qualitative. In qualitative methods, we have Rosette test, where if it came negative, that means she had fetal-maternal hemorrhage of 2 ml. We will give 300 microgram of anti-D to the patient. But if Rosette test came positive, that means she had fetal-maternal hemorrhage of more than 2 ml. Then we will go for the KB test, Klein-Hor-Bethke test, which is the acid dilution test, ma'am, where we can calculate the amount of fetal-maternal hemorrhage, which is based on the principle of acid dilution, ma'am, which is acid in KB test, ma'am. It is there are some cases like in sickle cell and thalassemia, there are slight what I will say the precision is less. In that case, we'll go for the flow cytometry, madam.
So you how much amount 300 microgram this dose, this standard dose, how much amount of fetal RBC or blood does it take care
Ma'am,
of?
300 microgram will cover the 30 ml of the whole blood that means 15 ml of the RBCs, ma'am.
Yes. So if the fetal-maternal hemorrhage is more than that, then you may repeat the anti-gamma
Ma'am,
globulin.
ma'am, for the fetal-maternal hemorrhage more than 30 ml of blood, for every ml of blood, we will add 10 microgram to the dose, ma'am. There are only 0.3% chances that there will be more in fetal-maternal hemorrhage more than 30 ml.
So what is the critical titer of ICT?
It is used to be 1:16, but it differs. It depends. There are differences in the different laboratory, which we assume that it is 1:8 to 1:32 is the critical titer for the affection on the baby.
So in a particular lab, the critical titer is 1:16, and your patient is showing 1:16 titer. So now what will you do next?
Ma'am, if critical titer is 1:16, then if patient is first time affected, then I will repeat. I will go for the MCA Doppler, MCA PSV Doppler, ma'am, from 16 weeks of gestation. If if her MCA PSV
From
come,
16 weeks, why from 16? What was madam's question?
ma'am, sorry, ma'am. It is if critical titers came 1:16, then what we will proceed.
So
Then
if
I will do
it comes at say 30 weeks, then why do you want to go back to 16 weeks?
Sorry, ma'am. Actually,
There
whenever
is
it
no
comes
need.
to yes, ma'am, there is no need. If
As
it is
soon as you detect that it has reached critical level, then you will go for
MCA PSV Doppler, ma'am.
MCA, PSV.
Yes,
If MCA PSV Doppler, there is if we need to monitor for every week. Ma'am, if the MCA Doppler came 1.5 multiple of median, then we need to go for the cortical synthesis to know the hematocrit of the patient. If hematocrit of the baby came less than 30 grams,
What actually happens in the middle cerebral artery because of Rh negative status?
Ma'am, increased velocity. There is increased velocity of the blood, ma'am, as the cardiac output is increased due to the anemia, and the resistance is also less.
So MCA PSV goes on increasing. If
Yes,
it
ma'am.
is, if it remains 1.2, 1.1, 1.2, then what will you do?
Ma'am, we will monitor again for weekly MC PSV will do, ma'am. We'll do MC PSV till there is increase in the titer or increase in the trend.
And if it does not rise?
And we will continue pregnancy till the term, ma'am.
Till term, okay. And supposing if it goes above 1.5 or it touches 1.5, then?
Ma'am, then we need to do photosynthesis, ma'am.
But if patient is 38 weeks and it is 1.5, what will you do?
Ma'am, we will, ma'am, we will do again. We will go do MCPSV for
It
1
is,
to 2
it
days.
has reached. Huh?
Ma'am.
Why do you want to extend
Ma'am is
pregnancy?
saying the patient has reached the maturity.
Then we can
Patient is
terminate
already
baby, ma'am.
38 weeks.
Patient is 38 weeks according to ma'am.
We can terminate baby, ma'am.
We should terminate the pregnancy because
Yes, ma'am.
baby will be more safe
More safe,
the uterus,
and there
ex
will be
utero.
yes, ma'am. We can avoid her from the excessive exposure to fetal maternal hemorrhage, ma'am.
And precaution should be taken during labor.
Ma'am, in the first stage of labor, we should avoid the
Will you allow vaginal delivery?
Yes, ma'am.
Will you allow vaginal delivery?
Yes, ma'am. If patient is less than 32 weeks and there is a more severe affection.
Yeah, we are talking about this patient 38 weeks.
Yes, ma'am.
MCA,
So, ma'am, I will do the
PSV.
normal vaginal delivery.
So how will you? She will need induction, na?
Yes,
How
ma'am.
will
I
you
will
induce?
ma'am, by Cerviprime gel, dinoprostone gel. So if the biceps score is poor, then I will go for the priming of the cervix via dinoprostone gel. And if the cervix is favorable, bicep is more than 7, then I will go for the amniotomy and the oxytocin, ma'am.
Why not separation of membranes?
Ma'am, separation of membrane will increase the chances of fetal maternal hemorrhage, ma'am.
So how will you manage the labor? Any special precautions will you take during delivery?
In first stage of
First
level, I
stage,
will.
second stage, third stage.
Yeah, systematically
stage,
you just
yes,
keep
ma'am.
on telling us.
In first stage of labor, I will avoid giving the argometrin to the patient, ma'am.
Huh? We never give ergometrin in first
We
stage.
never give ergometry in the first stage.
Yes, ma'am. Yes, ma'am. We will never give, ma'am.
In fact, we do not give
Yes.
ergometry even for the prophylaxis of postpartum hemorrhage. We give
In
oxytocin.
first stage of labor,
After
I will
delivery.
monitor I will do continuous electronic monitoring of the baby. In the second
Okay.
stage of labor,
No. Do you give fundal pressure routinely?
no, ma'am.
Should it be given?
No, ma'am. It might.
More
Comes
so
under
in
don'ts.
RH negative, it should never be given. No
Yes, ma'am.
massaging, no fundal
No
pressure.
massaging to
Madam,
uterus. No.
as such, fundal pressure should never be given in any
Should never be
pregnancy,
given.
irrespective of the RH negative status. It should not be given. It comes under
Yes.
the don'ts in
Yes.
labor.
Yes, ma'am.
So in second stage, what precautions will
In
you
second
take?
stage,
In second stage, ma'am, I will cut clamp immediately after birth, and I will keep the cord as long as possible, and on the placental side. I will collect cord blood from the maternal side, and I will not clamp the placental cord. I will allow the blood to fall out from the placenta, and I will allow the placenta get expelled spontaneously.
And
if
we,
you have
and
given
we will minimize
episiotomy,
the use
any
of instruments.
Sorry, ma'am.
We try to avoid instrumental delivery in RH
Yes, ma'am. We will try to avoid instrumental delivery.
because it
and
increases
if
the
you have given
incidence.
episiotomy, then you will try to cover it with
Mops.
wet sponge. You want to avoid the blood contamination.
Yes, ma'am.
Is there
And
any
we-
chance of increased risk of isoimmunization if there is a cesarean delivery as compared to vaginal delivery?
Yes, ma'am. There is increased chances of more chances of the fetal maternal hemorrhage, as the incision site is there, and the placenta will expel, and the blood from the placenta will expel in the peritoneal cavity. That will
What
lead
precaution
to.
should be taken?
Ma'am, proper mopping should be done. Proper
Mopping?
mops should be kept on the side, that it will decrease the spillage of blood in the peritoneal cavity, and the proper cleaning of the peritoneal cavity should be done as far as possible. As much as blood spilled in the peritoneal cavity, we need to remove it, and we will avoid the manual removal of the placenta.
Yes.
Would you like to take any blood sample of the newborn baby?
Yes, ma'am. I will collect
Okay.
blood from the cord for the direct Coombs test, for blood grouping of baby, for hematocrit of the baby, and for the bilirubin of the baby in the baby, and the reticulocyte count in baby, ma'am.
In how many percentage
Direct
of
Coombs
cases
test is
does
positive. If direct Coombs test is positive, what will you do?
If direct Coombs test is positive, ma'am, that it means that already elimination happened, ma'am. Then there is no need to give postpartum anti-D prophylaxis, and we will monitor the baby for any changes in like jaundice or any other symptoms, ma'am.
Baby will be handed over to neonatologist.
Neonatologist.
Even hemoglobin is very important in that case, no? That whether it is decreasing, increasing, patient developing, baby developing jaundice. So they need a specialist care.
You
So suppose the case has H mole, right? So H mole does not have any fetal tissue. So after suction vacation, would you like to administer anti-D or not?
Ma'am, yes, ma'am. I will administer the anti-D according to ACUG
Right.
guideline, because, ma'am, in complete mole there is no organogenesis, but the diagnosis of the complete, whether it is a complete mole or the partial mole, is depend on the histopathology, which will immediately not available. So it is better to administer the anti-D to the patient.
Yeah. Good.
Thank you, ma'am.
And
supposing
in case
if
of
patient is giving history of affection of previous baby had hydrops, and she also had IUD. So how will you manage the patient if patient comes to you in first trimester?
Ma'am, if patient comes to in first
Yes, bad
trimester,
obstetric history, no live issue.
if patient comes with a previous affection of baby, then there is no need to do antibody titers. Ma'am, we will directly go for the monitoring by MCA PSC doctor from the 16 weeks, ma'am. And again, the
Huh?
management from 16 weeks.
Okay.
Ma'am, again, the management will be same. We will monitor MCPSV for every 2 weeks, 1 to 2 weeks. If it is more than 1 to 1.5 multiple of median, then we will go for the chordosynthesis. And it came less than hematocrit is came less than 30, we will go for the intrauterine transmission. And if chordosynthesis in hematocrit, if hematocrit is more than 30, then we will again monitor with MCA PSV with chordosynthesis week in every week, ma'am.
Can you tell us something about intrauterine transfusion? When is it done? How is it done?
Ma'am, intrauterine transfusion done in the 3 ways, ma'am. IDD. It is intraperitoneal.
Indications for intrauterine transfusion?
Ma'am, if hematocrit is came less than 30%, ma'am. Ma'am, and the fetal hydrox will occur if less than hematocrit is less than 15%. So we need to give the intrauterine transfusion in.
So usually when MCA PSV is more than 1.5, mostly the hematocrit is less than 30.
30.
Yes.
You are not going to do hematocrit once and then again you are not going to do the invasive procedure, isn't it?
Yes, ma'am.
So it is done in the same sitting.
Same sitting. It is in the same
Results are
sitting.
available within few
Ma'am,
minutes.
yes, ma'am. Chordosynthesis is done in the institute where the facility of the transfusion is available. So in the same sitting, we will do the intrauterine transfusion. There are 3 types of the intrauterine transfusion, like intravascular, intraperitoneal, and the combined. In the intravascular transfusion,
For that, you tell me about the blood, the transfusion which you are going to give. What instructions will be given to the blood bank officer?
ma'am, we will transfuse O negative blood group, ma'am, with freshly O negative blood group, freshly transfused, cross-matched with the maternal plasma, and the according to ACOG recent ACOG guideline, that blood should be K negative, ma'am, KL antibody negative.
It should be irradiated or
Can you, just because you have now told about KL, what is the significance of KL antibodies? Or what is?
Ma'am, if KL antibody is present in if KL present in came positive, ma'am, then the KL antigen directly attacks on the erythroblast cells, ma'am. So there will be anemia directly without hemolysis, ma'am.
So that there is a need of this MCA PSV. Here there will be no jaundice, but
Yes, ma'am, there will be no jaundice.
anemia
There is no hemolysis. There will be no jaundice, ma'am.
so Vivek,
so
we are ready.
this is KL negative and
Ma'am, hematocrit must be 70 to 80%, ma'am. And the blood should be irradiated for the avoiding the host versus graft versus host reaction, madam. So we need to eradicate the blood, ma'am.
Okay. How much amount of ibuprofen? How much blood will be given?
Ma'am, that is calculated from the formula. That is the formula is the hematocrit, the initial hematocrit, gestation, ma'am, hematocrit of the baby minus initial hematocrit upon hematocrit of the transfused blood to be transfused, ma'am.
Okay, there are 2 different formulas. So you have calculated the amount to be given.
Yes,
so
ma'am. Another formula is gestational age minus 20 into 10.
So how is this transfusion given?
Ma'am, in intravascular transfusion, we will under sonography guidance, we will transfuse to the in the umbilical vein. The transfusion rate will be 1 to 2 ml per minute. And as the transfusion is completed, we need to again flush that needle with normal saline and aspirate again aspirate from same needle, and the 0.5 ml of the first aspirate should be discarded, and again the next blood will be calculated for the hematocrit of the blood of fetus, so that we will check the how much blood hematocrit is increased in the blood.
So Vivek, what is amnestic response?
Amnestic response is the development of antibodies in the subsequent exposure, madam.
No. When mother had developed antibodies and now she is carrying a negative fetus, even then that response will be exaggerated. That is called amnestic response. And what is the meaning of sensibilized?
Ma'am, in sensibilized, ma'am, patient mother is exposed to the RH positive blood RBCs of the baby, but the antibodies are not developed. It's called sensibilization, ma'am.
So in the next pregnancy, they show their effect.
Yes, ma'am.
And can you tell us that grandmother effect which you were telling us earlier?
In grandmother theory, ma'am, if the mother is RH negative and she had mother who is RH positive, so there are chances that in that pregnancy, there are chances that fetal maternal hemorrhage might be occur that made production of antibody in this current pregnancy mother. So she is already immunized and she can affect the baby in utero.
And suppose
In the first pregnancy, ma'am.
Yeah. So suppose you are planning external cephalic version in a breech patient. So would you like to protect with NTD?
Yes, ma'am.
It was not successful even.
Yes, ma'am. Even there are risk of the fetal maternal hemorrhage, ma'am. So we will
Yeah.
administer the NTD. There are
Yeah.
more and in the external cephalic version there are more chances and the large amount of the fetal maternal hemorrhage can occur. Then we need to administer the NTD and we might need to calculate the fetal maternal hemorrhage quantification of the fetal maternal hemorrhage, ma'am.
Yes.
That additional
So
NTD can be required in the external cephalic version.
Obstetric complications associated with RH isoimmunization.
There is a Miller syndrome. There might be preeclampsia.
Yes, preeclampsia is common. Then
Yes, ma'am.
large placenta. So
why
placenta.
does preeclampsia occur in RH negative
Ma'am,
pregnancy?
there is a placentomegaly, ma'am. There is increased resistance in the blood
Yes,
flow. In the
any
placenta.
placentamegaly may lead to preeclampsia because the disease is in the trophoblastic villi.
Yes, ma'am.
supposing patient is at a place where the facility of intrauterine transfusion is not available. Patient has reached 32 weeks, 32, 33 weeks. In CAPSV is also more than 1.5. Then what will you do?
Ma'am, then we need to do give the corticosteroid coverage and we need to deliver the baby, ma'am.
Either do that or transfer the patient to a higher center,
Higher center, ma'am.
isn't it? Or give
Is there any
steroids
role
and then
of immunoglobulins therapy?
Sorry, ma'am.
Any role of immunoglobulin therapy? New
Yes, ma'am.
research?
If patient is a RH negative and the husband is homozygous, and there are chances of affection of the fetus, so we can give IV antibody immunoglobulin to mother at the rate of the 1 milligram per kg baby weight before 12 weeks of gestation, ma'am.
20 weeks.
New research has come
Sorry, ma'am.
with immunoglobulin. We can sometimes delay the transfusion. Suppose we do not at that time and we do not have blood transfusion facility in our own center. So we can delay this by 3 weeks by giving immunoglobulin. This
Yes,
is
ma'am.
just a new research, yeah.
Suppose husband is homozygous and patient is desperate to have pregnancy. What are the other options?
Then if husband is homozygous and the patient is wanting to conceive and there is bad obstetric history, then they should go for the donors artificial insemination by donor of the RH negative. RH negative donor, madam.
If they want their own child,
Ma'am, if the patient husband is homozygous, there are 100% chances that next baby will the RH positive, ma'am. If patient's husband is heterozygous, then we need to
no, I am
pick.
talking about homozygous only. She can think of surrogacy, no?
Yes, ma'am, she can think of surrogacy.
And if the husband is heterozygous, then
Then
what is the...
we need to pick the RH. We need to do the blood grouping of the fetus while we need to transfer the Rh negative fetus in the ART center.
Okay. What is
Vivek,
the
can you
role of
elaborate? Can you elaborate on the Rh antibody? What are the different types of anti-D gamma globulin available?
Anti-D gamma globulin
How
available.
they are prepared, how they are given?
Ma'am,
These are given.
anti-D gamma globulin are prepared by the two methods, that is the fractionation and the flow cytometry. Ma'am, from fractionation, we will go by the Owen's alcohol. We will do serial fractionation, and this fractionated antibody will use for the only IM use. The names are portobulin and the gamma D. Are those are two of those are the came from the fractionation of the fractionation from the plasma, and the from the flow cytometry, madam. Uh, there are production of the gamma anti-D by ion exchange method. By ion exchange method, ma'am, there are two anti-D are available in market. From the cation ion exchange, there is a Rho-like anti-D is available, and by anion exchange, there is available Winro. Winro is in UK, ma'am. According to ACOG guideline, it is used for the immune thrombocytic purpura, ma'am. So it is not marketed right now in the India, as far as I know. And flow cytometric derivation of the antibody are used for the IV preparations. So the Rho-like can be used for the IV administration, madam.
You just tell me which cannot be given intravenous.
Ma'am,
That is very important to know.
fractionation, which came from the fractionation.
Yes, because it contains protein.
Protein and alcohol.
So it cannot be given intravenous.
Where is anti-D given?
In the deltoid muscle, ma'am.
Why not in gluteal?
In gluteal, there are chances of absorption in the subcutaneous tissue. There will less absorption, and there may be the less dose will be go to the body of mother.
You can also give an entorlateral thigh also.
Yes, ma'am. Quadriceps muscle, we also can give in the quadriceps muscle.
What is the limitation of MCA PSV? I forgot to ask you this.
Ma'am, MCA PSV is not effective after 35 weeks of gestation, madam.
Okay.
As the resistance
Before
is
35 weeks also, what is the limitation?
There is one important parameter. That's why we cannot use this at after 35 weeks.
PI,
Because something
PI
increases with this.
PI of the umbilical different veins now.
The mean increases with gestational age also. So after 35 weeks, it is not much helpful.
What about after IUT, intrauterine transfusion?
After intrauterine transfusion, madam, we need to repeat after 2 weeks. Again, we need to do the hematocrit of baby, as there is rate of decrease in hematocrit 1 gram,
Hey,
1%
is
per
the
day.
sensitivity same before intrauterine transfusion and after intrauterine transfusion?
No, madam.
It
As the
decreases because now the fetal RBCs are replaced by
Replaced.
adult RBCs.
Adult diabetes, madam.
Isn't it? So the hemodynamics change. It's not that
So-
reliable, but still we have to rely on it because we have no other
No,
option.
So Vivek, if the fetus is affected by isoimmunization, what is the sequence of changes which may occur in the fetus?
Ma'am, when baby is affected by isoimmunization, there will be increased destruction of RBCs by spleen. So spleen will be enlarged, and the increased load of the production of RBC will increase. That will lead to increase in size of liver. That will lead to hepatosplenomegaly and the enlarged abdominal circumference.
First,
the
there
next-
will be mild to moderate anemia,
Yes, ma'am.
right? Now, then hepatosplenomegaly. After that, if it's still not
There will-
treated,
There will be ascites, collection of
and
fluid in the peritoneal and the pericardial and the in pleural cavity.
what is that
Then there
condition
will
called?
be, sorry, ma'am,
What is that condition called?
hydrops, ma'am.
Yes.
fetal
yes,
hydrops. Collection in more than 2 cavities, it is called hydrops. There will be
when there is significant hemorrhage, there is one particular clinical finding through which we can pick up significant hemorrhage.
that is Buddha sign, ma'am.
No, that's ultrasound finding. Any
Yes, ma'am.
clinical finding.
Clinical finding, hollow signs, ma'am.
Decreased fetal movement. If the patient is
Decreased-
complaining of significant decreased fetal movement, we may think we have to rule out significant fetal-maternal hemorrhage. And then
Hydrops has developed. If already
signs?
hydrops has developed, then how will you manage?
If already hydrops develop, then we need to give intrauterine transfusion, ma'am. If hydrop development means baby is severely affected with a severe anemia, so we need to give the intrauterine transfusion, and after 1 to 2 setting of the intrauterine transfusion, hydrops will be revert back, and the placentomegaly is the last symptom to reverse.
How is the prognosis?
Ma'am, prognosis is poor.
In
Baby
hydrops.
might land up into the in postnatal period. Baby might land up in the jaundice or icterus, and baby might die.
Long-term effect.
Sorry, ma'am.
Long-term effect also.
Ma'am, in long-term effect, if a baby had received intrauterine transfusion, there is a sensory neural hearing loss, and there is a cerebral palsy in the baby.
Yeah.
Yes.
You answered all the questions so well. Well prepared.
Yes.
Thank
You
you so
were
much.
very
Ma'am.
well prepared.
Very well
Really, I
prepared.
appreciate.
Really.
Thank you so much, ma'am.
Yeah. Great performance.
Thank you so much, ma'am.
I think we have covered all the aspects, isn't it,
Almost
madam?
all the aspects. Yes,
Almost.
yes, ma'am. Almost all the aspects. It was a pleasure moderating with you.
Thank you so much, ma'am.
Chairpersons, will you like to add?
Yeah.
I would just like to add that Dr. Vivek, you did a great job. And the examiners, I mean, I was remembering my PG days. Shashi madam and Sulba ma'am, you were so meticulous and particular about asking everything. You took out all the knowledge and all the information from the candidate. Nothing was left to imagination. So when he is really practicing, he will be remembering every little thing when he sees the Irish negative, gravida. So it was a very big learning experience for me also. I revised so many things thanks to Dr. Sushma and Dr. Pragati. And it's a pleasure to be listening to this exam.
Really, it was very nice discussion. Thanks to chairpersons and also Dr. Vivek, presented
Thank
very
you.
nicely. Very nice.
Ma'am, it was
Subha ma'am,
possible.
thank you very much for coming.
Ma'am, it was all possible due to well guidance from my HOD madam, Dr. Patil madam, and my mentor, Dr. Neelam ma'am. So
Yeah.
they kept me hammering to prepare well.
Yeah,
So you are
congratulations,
lucky,
Dr. Rajesh.
you are
also.
lucky to have them with us.
So how far is Gondia from Nagpur?
It's ma'am like 150 kilometers, ma'am, 2 hours by
7
train.
kilometers.
3 hours.
it is-
It's a 3 hours distance.
I see. No, this
Rajeshri, this is the way one should get the students prepared for case presentation. I'm
I
really
really
very happy.
appreciate. Give
Rajeshri
our
was our
compliments to your
student at
teachers.
GMC.
Nee,
Very
Dr. Rajesh is staying there also, constantly guiding and really always with us for all PG webinars. Thank you, Dr.
We are
Rajesh.
really
ma'am.
blessed for
Thank you
by
so much, ma'am, for this opportunity, for giving me this opportunity as a chairperson and for giving the opportunity to my institute to present this case.
Yeah, it's our
Like,
pleasure
and-
also.
My students have been taking a lot of efforts in spite of alternate day duties. They have been working on it continuously.
Ma'am,
And
I
I
had
feel
one
proud
query.
of it.
I had one query from the examiners. Madam, you put in queries about external cephalic version and fundal pressure. Of course, in institutions, still it is being given. Even in private sector, it is being given. But like external cephalic version, does the generation of today knows about it? Have they ever seen it being done, or are they aware it is being done, or it is only
Ma'am,
from
it is decreasing. It is decreasing, but still, especially in transfer slide, in medical colleges, it is being shown. But they should be aware of the term
Yes,
and
yes,
they should know
be
what actually it is.
Because I mean, Pragati will also agree. We have done internal podalic version in the transfers, second
Yes, yeah.
transfers of twins.
Yeah, yeah,
So
that's the
many
only
times.
indication.
Yeah,
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 that's the
yeah.
only
But,
indication
yeah,
of internal
but,
podalic version.
but madam, with the liberal use of cesarean section nowadays, I really think that we were having a webinar on instrumental deliveries in the past. There's nothing which the postgraduates have seen now what we did in 80s, 90s, and you must have seen
Yes, yes.
70s, madam.
In fact, our postgraduates are not getting adequate training on vaginal breech delivery.
Yes, ma'am.
Then in second gravida, whose pelvis is normal and fetus is not extended, all the criteria are met. We must tell them how to take a vaginal delivery also, because the incidence of cesarean during our time it was 20%. Now it is crossing 50%. Already it has crossed 50%.
Yes.
So that art must be learned. But we
Actually,
do
this
have
art needs to be
vaginal
revised
breech.
back in certain cases.
Yeah.
I will like to thank NOGS for giving me opportunity to perform here and give chance to express in front of you. And I will love to also thank to my fellow resident and junior resident who are junior to me, allowed me to study well. Thank
Give my compliments to your teachers. They have prepared you very
Yes,
nicely.
yes.
Excellent preparation.
So,
All the
pass हो गया
best,
फिर
all the
तुम?
best,
You're
better.
already done.
Vivek, all the best.
Thank you so much, ma'am.
Already
All
done.
the best.
So at this moment, I just wanted to
Yeah.
inform that this coming Sunday, that is on 25th of February, Nagpur OBGY is organizing one live operative workshop, laparoscopic live operative workshop, especially from Gondia. All the PGs who want to come, it's going to be a very mega workshop. Dr. Rashri, you can take
Really,
it.
if possible, please send the
And
PGs.
your PGs also send
Hardly 1,000 is this amount is
registration
there.
amount is only 1,000.
So they will get, because many good faculties from
All over
Lucknow,
India.
they are coming.
Yes.
And there will be very good teaching also, practical workshop.
We will love to come there, ma'am.
Discussion, please. Very nice discussion.
Thank you so much, ma'am.
I'm thankful to
Before
Dr.
we close, I would like to
Doctor.
congratulate Sushma and Pragati. Heartiest congratulations
Thank you,
to
ma'am.
the
Thank
duo
you.
and your team.
Ma'am, your blessings are always with us since beginning.
Congratulations from my side also to all the organizers.
Thank you.
And thank you for inviting me here.
It's 8 o'clock.
A sincere thanks to Dr. Shashi also for being a very good co-examiner.
Yeah, we have
both
met for
did
the
job.
first time, but we coordinated well, Dr. Sulava.
No, but both the examiners really did the job very well.
Yes, the range of questions you have been putting and the way they were
Wonderful.
being examined was really wonderful. Wide
Thank you.
range.
And now we are very,
Can
we
you
are
please
very
stop
excited
sharing?
about
We'll have one
long time I'm
photograph
seeing you.
together. Can you please stop sharing, Vivek? We'll have one
Yes.
photograph, group photograph. All faculties are
Okay.
here.
Okay, okay.
Otherwise,
Yes,
the
ma'am.
chairperson will just leave
Yeah,
the platform.
even,
That's why. Yeah, we'll have Ruchi.
Yes, ma'am.
Like,
Dr. Jyotsna, please, please be seen. Please open your video.
Dr. Jyotsna.
Right from Cuttack. Hello, Dr. Jyotsna here.
Welcome, Dr. Jyotsna.
Vivek and Neelam, are you seeing in the screen properly together?
Picture.
The light is not proper on your face. It is, you
Now
can
it's
see
done.
the,
Now
yeah,
it's okay.
it's
Now
okay now. Please just, Ruchi, please have one more photograph.
Unmute yourself, Jyotsna.
One second, madam. Dr. Jyotsna was not there. 1 second. Huh?
I am there.
1 second. 1 second. I am putting the other pictures first.
I've also taken screenshot. I'll forward to Pragati.
Thank you. Thank you. Monica is very instant in doing all the work.
Okay.
So,
Really, I should convey my thanks to today's examiner, Dr. Shashi Kabra and Dr. Silva Joshi Madam, for examining this so interesting case presented by Dr. Vivek. Thank you so much. And because by the time I will be giving vote of thanks, maybe some have, unlaunched from the webinar.
Actually, sorry, because we are having drama practice. We
Yeah.
are planning drama on 10th of this March. So we both are acting there, me and Pragati. So we had to leave around 8:45. So that's please
And I tell you,
excuse
the
us.
drama is, scripted by our president, madam only.
It is on male pregnancy.
We have
Manika,
listened to
like the topic.
Sushma madam, we listened in the hysteroscopy carnival. She is she's a very artistic surgeon.
Yeah, she's very creative. So this drama is on male pregnancy. So it's on 10th March. I again invite you all to see this drama. All our Nagpur stars are working and it's scripted
If
by
it
Dr.
is possible, please Gondia, please be there and other also faculties.
Nagpur rocks with energy, yes, sir.
Yeah.
Yes.
Yeah.
Yeah.
Picture done?
Done.
Chalo, let us move ahead.
Yes, yes.
Come on, we can go ahead now.
Go ahead with the talk.
Now we will proceed. Now we'd like to proceed to our next session, that is Pearls of Wisdom, with the topic of ultrasound monitoring of Rh negative pregnancy. And I would like to welcome our chairperson, Dr. Rajeshri Patil Madam, our dearest. Madam is MBBS, MD OBGY, attended various conferences at national and state level, moderated in panel discussion in conferences, attended various CMEs and workshops, publications. Madam has international 7 publications and national 1 publication, peer reviewer for OBGY journals, participated for study on international survey on practice variations in management of 3rd stage of labor for Global Network of Perinatal and Reproductive Health 2002 in Bulletin of WHO, participated in IVF ET workshop in Fertility Research Center Madras, attended refresher course 2003, Medical Education Technology 2006, Good Clinical Practices and Biomedical Research Workshop 2014, Regulatory Updates in Clinical Trials 2015, organized personality and skill development, stress release and meditation workshops for undergraduate students and faculties in 2009, 2012, 2019 and 2020. Next chairperson for the session is Dr. Monica Singh. Ma'am has been awarded with 10 gold medals, MBBS professor at Ellen Medical College, Bhopal, consultant reproductive medicine, endoscopist, sonologist, Bhopal Fertility and Endoscopy Center, Bhopal, secretary, MP chapter ISAR 2023-24.
It's okay. I think that's enough. Thank you.
Thank you. And our speaker for today is Dr. Jyoshna Rani Panithram.
It's fine. Am I audible?
Yes, yes. Please.
You are audible.
You're audible, but voice is breaking in between.
Voice is breaking.
Some vibration, but just please go on talking.
So should I share my screen?
Yes, sure.
Is it visible?
Yeah, we can see.
You can see. So I will go to the
First, you have to
one
unshare.
introduce me.
Who is sharing?
I think
I am sharing my screen.
No, somebody
no, I
else.
think
This is
Neelam,
other
Neelam.
person is sharing.
Neelam, please stop sharing your screen. Dr. Neelam? Yes.
Now your screen will
Yes.
be. Yes, you are now
Is it-
visible. Screen is visible.
Whole screen is visible.
No, not a full screen. Your screen is coming off a whole,
You
Slide
have to go to
sorter.
on the slide one.
Yeah,
Yes, yes.
now it is coming.
But
Now
I am
it
not able to see it.
Uh,
Just 1 minute, please. Just wait. Just wait. Let me. I don't know.
next screen. Do next screen.
Huh?
Do one thing. Stop.
Is it visible now?
Stop sharing and reshare again.
Sorry, sir.
Stop share, then reshare.
Stop share, then reshare. Okay.
The option is there at upper
Stop
side.
share. Yes.
Yes. Now again start sharing.
Yes. In the slideshow. Is it visible?
No,
No.
no.
No, you didn't reshare.
Is it now visible?
No, no,
One
you have to
second.
share it.
Oh, 1 second. 1 second. If you have done sharing, then it will share.
I have
Start.
set the screen. Okay.
One
Then
second.
I have to share my screen, no?
Now you
Yes.
share after making a full screen.
Yes.
Is it
Full,
visible now?
full
But
screen
again,
is
all
not
the slides,
coming.
we can see all the slides.
You
Now
can see.
slideshow. Press on the slideshow.
Is it okay?
Yeah.
Yes,
Yeah,
yes.
now it's fine.
So how can I make this small? This I will minimize it. Okay. So good afternoon, good evening, everyone. I am thankful to Nagpur OBG Society. I'm audible.
Yes, yes. Please go on.
So I am
Yes.
thankful to OBG Society Nagpur and Government Medical College faculties Gondia. Special thanks to Dr. Pragati Madam. Before starting my topic, this is what we are. We are the multitaskers. We have to manage the patient with all the knowledge of medicine, surgery, OBG, ultrasound, anatomy, and all these things. For that, before managing a Rh negative pregnancy, an obstetrician should be well answered about few questions. That's why my presentation is a case-based questionnaire is to solve all your problems. So basic thing, the AB blood grouping system is two types, ABO and RH. ABO, everyone knows AB, AB and O antigen, and RH system is C, C, D, E, and G. The RH antigen is located, my upper part of the screen is visible. Hello? Hello?
Yes, we can see it.
You can listen to me?
Yes, yes, we can see it now. We can
So-
see your screen. We can just, this is very good to watch it. No problem.
So the Rh antigen is located on the short arm of chromosome number 1. There are 6 genes responsible for production of Rh antigen, 3 on each chromosome designated as C, C, D, I, or E. When the father is, we all have a very nice discussion regarding every details of the Rh disease. Just I am going to the brief which will be pertaining to my ultrasound monitoring. So if the father is Rh positive and homozygous and mother is negative, there is every possibility that all children will be positive. And there is, when the father is heterozygous, there is 50% chance of being Rh negative. So I don't know why my screens are not visible in the upper part. So when the Rh negative mother has a Rh positive fetus, I'm not getting the, sorry. How can I make the screen, these things small?
Madam, you have to go to the view option.
View?
View option at the top, and view option may you have to minimize, you have to make it 50% or something.
View where it is?
A view is at the top of your screen.
So I have to, where
You
it
go
is?
to the view option.
Top of more mein hai?
Uh,
I don't know, I cannot.
or madam, you can send your slides to the tech team and they can run it for you.
No, the problem is that mine are all videos, I cannot.
Okay.
So again, let me, view option. Acha, view.
View
Okay.
option.
So,
Madam,
I
there
will-
is another option. You can duplicate. 1 second.
I can
Duplicate your
my
screen.
slide.
There will be one option to duplicate screen. 1 second. It is there or not? It is not there.
Because I cannot read my slides.
Why you cannot read your slides?
No, sometimes
The
I
upper
was
part of
seeing
the
the,
upper part is
yeah.
covered by the all the faces and all these things.
Yeah, you have to make gallery on the right side, madam. Madam, there is in the,
You can choose your gallery. There is view option on the right hand side. Right hand, upper right hand side view option
I
is there.
choose the
View.
gallery. Again I have to say.
No. Yeah, you need to share because your screen is not visible now. Yeah. Now you are visible. Now do one thing. Full screen the screen.
Okay.
Your slide full screen. Make it full screen. Oh,
Array.
no.
Otherwise, you do one thing. You can share your slides to
Don't
Mr.
close
Ruchir.
it. Don't close it. Don't close
I'm
it.
not closing it. Okay, I will. I'm not closing it.
Share your slides to Ruchir. He will
No,
present the slides for
Just-
you.
There is some
just-
videos, madam. That's why she is.
Some
That's
problem
why-
is there. Yeah.
Can you see now?
I'm not able to see the top of my screens. So
Okay. For that, there is a right hand side. There will be a view button.
yes,
Go to their view.
view button.
Hide no. Hide.
Hide thumbnail video.
Yeah. Hide thumbnail video.
Still also.
So you will not able to see anybody else.
No, I'm not able to see the top part of my screen. Okay, it is all right. I will just read it. So
One
again,
second, madam.
one minute, please.
Side by side speaker. Choose side by side speaker. In view, there is a side by side speaker.
More.
Not on PPT, on Zoom link.
Zoom link more.
Side by side speaker.
Side by side speaker, thumbnail, active speaker video, and one is thumbnail, the other is show grid view.
Side by side speaker. Choose that.
Side by side speaker is not there. I don't know how to do.
Okay. Standard.
I used to keep always the top, but I don't know what happened this time. So non, क्या करूँ फिर?
One second.
What happened?
No, you can share your slides to Mr.
I
Ruchir.
cannot. There are videos. That is the main problem.
Okay,
I
okay.
cannot. So, okay, I am just going to read it. Should I make it small screen or something like this?
Yeah, you can do it like.
Huh?
In small screen, what do you do, madam?
Okay,
Please
okay,
go to this. Go to your presentation. Go to
Yeah,
your presentation, madam.
I will go to my presentation. Okay.
Okay, then choose this the button, the slideshow button. Not do that, but the rightest part there is there, na? Rightest button in that. Please choose that.
Right bottom.
That right. Not this.
Okay, it is not.
Back. Escape.
Escape then.
That right now it is a note sequence. Go right of slideshow, right, normal, then right. No, right. That only.
This one.
One. Right, madam, right.
This one,
Not
right.
zoom,
is
not
there.
zoom. You are sorry, leftist
Slide-
part. Sorry,
slide
my
to the correct window.
pardon. Left.
Let me just-
Left. Yes, that yes. And
That is the
there is one there in add-ins. There is a one arrow near add-ins.
near
Add-ins in upper part.
add-ins. Okay.
No. Side, in that right side there is one arrow. Escape button. That yes, this arrow. Yeah, put that.
This arrow.
Yeah, collapse. Press it.
Then
And then 1 second. There is the zoom is now you can increase to up to 70%. Zoom.
this one.
Zoom.
Zoom.
Zoom means zoom of this PPT. That
PPT. So I will go through only the PPT. Or that slideshow will not be. That's what you are saying.
yeah. So make it bigger. That so everybody 70 around 70.
No, the
Yeah, this will be readable. 70 around 70 it will be readable.
Okay, should I go to presenters view then? I don't know.
No, this will be okay.
Okay.
It is
So I,
visible.
everyone is able to see.
Yeah. Even 70, around 70, not more than 70.
Okay. Is it okay?
Okay, this is visible.
So should I go now?
Yeah.
Okay, everything is fine.
Uh,
Yeah. Can you see everything now?
Yeah, I can see now.
Yeah,
But
then
I
go
don't
ahead.
know
No
video
problem.
will play or not. So when the everyone knows that when there is sensitization of the Rh negative women with Rh positive fetus, there is production of iso antibodies, and subsequently there will be hemolysis. So if what happens then, that sensitization can occur at any time, antepartum, and during any of the procedure, as madam has already told, external cephalic person, amniocentesis, chordocentesis, or any of the procedure, and during intrapartum. So the risk of severity of sensitization increases in each pregnancy. Without any prophylaxis, the risk is 16%, whereas if you take adequate time Rh anti-D, the prophylaxis, the risk is decreasing to the 0.1%. So the most dangerous complication is the fetal anemia, which subsequently lead to hepatosplenomegaly, ascites, edema, pleural effusion, and pericardial effusion, ultimately hydrops fetalis. And then the sequence continue, and there will be heart failure and fetal demise. What the ultrasound has the role in managing Rh negative pregnancy? Ultrasound, first, as in all other pregnancies, it is the earliest it should be done to know the correct gestational age, which is very, very important. All the obstetricians should know how to give the correct gestational age, because we often get the report from the ultrasonologist or the fetal, not the fetal medicine, ultrasound report, so many EDDs. So the patient usually get confused, and our MOM value depend on the gestational age of the fetus. So very important to know the correct gestational age. Next is as usual in other pregnancy, first trimester scan, which includes aneuploidy screening, second trimester anomaly scan, and fetal echo is usually required in Rh negative pregnancy. Fetal cardiac function to know any problem in the heart as a result of there is hydrops or not. And recently it is being added that fetal HQ. And next, the most important is ultrasound has a very, very, very important role in detection of fetal anemia, which is, again, I repeat, it is the worst complication, and the mode of treatment of fetal anemia, which could be an emergency management, that is ultrasound guided chordocentesis and intrauterine transfusion. So now I am going to my case. She is a lady of gravida 6, para 2 with 3 abortions. Rh negative, come to me at 13 weeks. She is a known diabetic. History of IUFD, listen carefully. There is history of IUFD at 34 weeks due to hydrops. Taken 1 dose of anti-D in the 3rd pregnancy. So what is your line of action? As it is already discussed, the husband blood group ICT with titer. So if the ICT is found to be negative, then it's okay. We are happy. Repeat all the ICT at 26 and 32 weeks. And if it is multi, repeat it monthly from 24 weeks onward. Here is the change. What you have discussed, I think this is the correct one. If the ICT is found to be positive, serial estimation monthly. When there is ICT titer is suddenly increasing, it is significant. So now the patient is ICT positive, 1 in 32. Should we give antepartum prophylaxis? No. Women who are ICT negative only should be given anti-D, that you have already known. And the first dose is 300 microgram at 26 to 28 weeks, and second is 26 to 32 weeks. Women who are ICT positive, already sensitized, should not be given. For successful immunoprophylaxis of anti-D IgG should be given as soon as possible, but always within 72 hours. Not given if the patient has not taken within 72 hours, within 9 to 10 days, one can give. These are all the obstetrician you must be knowing. Just I am saying for the. So with this, what more is suggested? You do all the investigation of the first trimester. Recently, it has been added that NIPT for Rh negative is already introduced. Medgenome is doing it. Of course, the cost is more. So you can advise this also. Another thing is the PIH is more common in RH negative pregnancy. Uterine artery PI is a must. Nowadays, it is a must in all first trimester screening. So that you should do. Next, what is our mainstay of management? We know that she is RH positive and she is sensitized. ICT is positive 1 in 32. She has a bad obstetric history, already lost the baby, gravida 5. With all these puzzles, what is our next line of management? Fetal MCA Doppler peak systolic velocity monitoring is the standard standalone test for diagnosis and monitoring fetal anemia. So here the key role of the obstetrician to take the MCA Doppler in a right way. So what you have to do, you must be taking the BPD, take the BPD plane, go below, see the wings of sphenoid, then put color, then zoom it, then put color, put the color box as small as possible to get the better color flow. Then identify the circle of Willis. This is the circle of Willis. You identify the circle of Willis, visualize the entire length of MCA and enlarge the area of MCA so that it occupies 50% or more than the screen. This zooming is very, very important. Zooming and color flow, then you put the color. This is very, very important. And the other thing is that superimpose the sample volume on the MCA 2 millimeter after the origin of the internal carotid artery, and the ultrasound beam should be as parallel to the line of insonorization. Suppose our ultrasound wave is coming through this direction, and our flow is ultrasound blood flow is in this direction, and our insonorization should be parallel to this. So this is very, very important because any color flow uptake, the science is that there is cosine of the theta. When the cosine of theta is 0, then it is 1. When it is 90, it will be 0. So your insonorization angle should be 0, at least within 30 degrees. And take the peak systolic volume, and measurement is taken for 3 times. Now, again, I repeat, accurate assessment is very important because even if I took the 3 readings, it will differ. So you take minimum 3 readings and you can consider which one is the best. I don't think the video will run. Is running. Okay. So you just identify the branch and put the cursor as I have told. What happened to the next slide? Now, the middle cerebral artery is a proven method of choice. It has 95% confidence level. Positive likelihood ratio is 8.45. Negative is 0.02. And obtained at weekly basis gives us 98% accurate prediction of fetal anemia. There is a thumb rule that you can remember. The value of MCA PSB should not be double of the GA. Gestational, suppose the gestational age is 30 weeks, the MCA PSB should be within 60. That is a thumb rule, but the charts are available and you can put that on your chart. But while doing without any chart available or anything, because the obstetricians are busy people, and whenever just have a rough calculation in mentally that it is more than 60, so either I will be wrong in measurement or it is actually the baby is anemic. Let me measure for 3 times and put it on the chart. And the PSB is calculated in the multiple of medians that everyone know. So the risk of anemia is highest in fetuses with pre-transfusion peak systolic velocity of 1.5 times the median or higher. The fetal anemia starts at the antibody level exceeds 15, that is 1 in 1 to 8. Our critical value is 1 in 32, but nowadays peak systolic value is to be considered a better choice than the titer. So when there is already a sensitized mother with an anemic fetus, that doctor who is presented has already told, that is serial MCA PSB around 16 weeks onward. Another most important, the obstetrician should know, the past obstetric history is the predominant indicator of current pregnancy, possible intervention and outcome. When there is a suspicious of, or there is a death or IUFD or anything in previous pregnancy, then 6 weeks before the last mishap, you should be watchful. This one is very, very important for all the obstetrician. So previously affected pregnancy frequently follow up weekly for MCA PSB. Fetal transfusion can be offered as early as 16 weeks. So the case I have presented, she came to me at 13 weeks. I did everything. And 18 weeks, look, the MCA PSB is 1.15 mm. The value I put on the perinatology.com and it was found to be 1.15. I'm happy. ICT was same. So again, patient came to me at 27 weeks. 7 weeks, the PSB, MCA PSB is 1.4 mm. Considering the previous history, so we have started, we have advised for intrauterine blood transfusion. Intrauterine blood transfusion was suggested. So we should know what is fetal intrauterine transfusion. The indications are main fetal anemia. Causes could be all these. So we are considering maternal isoimmunization of RS negative mother with a positive fetus. Parvovirus can also cause the fetal anemia, TTTS, TAPS, and this one is important. I have gone through one case in my series that trisomy 21 with transient abnormal myelopoiesis at chromosomal abnormality. The baby came to me with hydrops, and I have advised for amniocentesis, and when I sent, it was found to be trisomy 21. They deferred transfusion and they have terminated the pregnancy. And these are the metabolic conditions where also we need fetal anemia. And what you have told, mirror syndrome, that is alpha 0 thalassemia can cause also mirror syndrome, and it mimics the RH isoimmunization cases. So why to give the blood transfusion? It will overcome the crisis. It will avoid fetal cardiovascular decompensation or deterioration due to anemia. This is important because the question was asked, if you get a hydrops, what to do? Hydrops, you can transfuse the baby, you can save the baby. So again, intrauterine transfusion, O negative irradiated leukocyte depleted double packed blood cell. Hematocrit of the donor should be as close as to 80, and so that the volume of blood to be transfused will be minimum. Procedure, you know, under local anesthesia, and site intraumbilical, intrahepatic, and intraperitoneal. We can mix these two also. So we are usually using intraumbilical, and when the baby is very small, you can go to intraperitoneal method also. So this is a video that I have done the transfusion. Look, this is the needle at 29 weeks. Are you able to see the needle? It's going, and this is the method. So you have to go transplacentally at the cord end site of the placenta and transfuse it. And you see the blood running through it. Are you able to see? Yes. Now, procedure you must be knowing. That is, we use 22 gauge spinal needle. I use Cook's needle. And sample of fetal blood should be first taken to know the present hematocrit, complete blood count, blood grouping, and RS typing. And the calculation is like this. And our aim to achieve a hematocrit level of 40 to 45% at the end of transfusion. Final sample of the blood is taken to check the final hematocrit. This will help us for the next time transfusion. So what are the risks of intrauterine transfusion? Preterm labor, PROM, fetal distress, cord accidents, chorioamnionitis, and formation of new red cell antibodies, graft versus host reaction. These are the value when first transfusion is done, decline, then the decline will be 0.4, whereas in the third transfusion, it is 0.2 gram per day. So keep the hematocrit value more than 25%. Here it is an important thing. Subsequent transfusion, depending on MCA, PSB action line is not 1.5 mmol, rather it is 1.3 mmol. Instead of 1.5 mmol, you should be more alert. After transfusion, don't think that the baby's MCA, PSB is not 1.5. Let me sit quietly. No. Then your monitoring alert line should be 1.32 mmol. Around 36 to 37 weeks, some study they have advocated phenobarbital. And beyond 34 weeks, usually transfusion is deferred. It is better to deliver the baby. So here in my case, she came at 30 weeks. After transfusion was given on 22nd December. This is a real original case. And post-transfusion, it was like this, 1.61 MOM, 30 weeks. So after 21 days, this was the picture. So it was again in 30 patient turn up at 31 week deferred on that day. It was 1.5 MOM and 1.5 to 1.6. Then considering the previous history, I have advised again for the IUT, but the patient deferred because this facility is not readily available in our place. So decision of cesarean was done with this sequence, considering intrauterine IUFD at 34 weeks, LACS was done, and this is the healthy baby, which is, he's now 4 years, I think, 4 years old. Case 2. That was a case without complication, only there is anemia, and because we are alert, we are managing the case and carefully, we could able to give the mother and healthy baby even at 34 weeks, 32 weeks, because the NI setup, NICU is good, so we could save the baby. But this is a case, I don't think videos will run. So this is a case, Gravida 3, Para 2, 29 weeks, previous 2 IUFD at 32 weeks, RS negative, partner is positive, not taken any anti-D, ICT positive, titer is 1 in 64. Baby presented with generalized edema, ascites, pericardial effusion, and this is the, I don't think the video will run. Are you able to see the amount of pericardial effusion here? This is the amount of pericardial effusion. This is ascites. Again, see how much pericardial effusion it is. And all the normal cardiac anatomy, ventricular arterial coordination is normal, and the heart is beating regularly, and there is associated hepatomegaly. With all these 3 things, presence of fluid in 2 or more spaces is considered as hydrospitalis, because this is a case of non-immune type of, it is designated as immune hydrospitalis. Then, and this is the hepatomegaly. There are measures how to measure, stamp it as hepatomegaly. These are the liver right lobe should extend beyond the inferior pole of right kidney. This is the, by that we are measuring whether there is actually hepatomegaly or not. And this patient, MCA PSP is 1.71 MOM and she is 29 weeks. IUT is advised, given twice. With steroids, she was delivered at 34 weeks. So you must be knowing this is hydrops and abnormal accumulation of serous fluid in at least 2 of the following, with or without placentomegaly. Then, and the skin thickening should be more than 5 mm, and pericardial fluid should be more than 3 mm. In last case, my case, what I have shown you, it was 5.6 mm. And there may or may not be polyhydramnios. Enasarca is best reserved for diffuse skin thickening without separation. So hydrops, you know, again, immune and non-immune. Due to advent of the anti-D, the immune hydrops is gradually decreasing in incidence and non-immune becoming more common. And with all this is the management protocol. You can get it from the net. First, do the ultrasound. Then if it is RS negative, no further investigation. RS positive, you can do the genetic of the father. If this is homozygous, it would be more alert. If and it's found to be positive, then here positive, then follow up every 2 weekly after 20 weeks with ICT and MCA PSB, and any suggestive of severe fetal anemia by ultrasound, MCA PSB more than 1.5 mm, increase in ICT titer more than 4 folds. Then do fetal blood sampling and fetal blood transfusion. And if this is found to be negative, follow up at 26 weeks with ICT and MCA PSB, and again at 29 weeks, again at 32 weeks and give anti-D one at 24 week to 26 and the other is 32. If the hematocrit is less than, then if less than 35 weeks prematurity, give transfusion. If more than 35 weeks, give steroid and deliver the baby. So my take-home message for Rh negative pregnancy, say no to immune hydrohospitalis, universal anti-D prophylaxis to Rh negative mother, timely referral intrauterine blood transfusion to the fetus if needed, because hydropic fetus has 40% survival, whereas non-hydropic fetuses are 85% survival. It is preventable. MCA PSB is the standalone test to predict fetal anemia. Goal is to stop alloimmunization, many step ahead from developing eye drops. An ounce of prevention is worth a pound of cure. We can do it. This is the healthy baby you see. The baby is delivered. How happy she is. This you can give to the mother and together we can win the... This is my final slide. Timely diagnosis and referral, proper management, genetic knowledge, eager to learn. Open your mind always to learn something, specifically the postgraduate students. You have presented very nicely your case. I am very, very happy that you have gone thoroughly to the subject. It is a challenge. Rh negative pregnancy with Rh positive fetus is a challenge, but definitely there is a solution. We can achieve it. Thanks. Thanks, everyone. Hello? I'm sorry, my video, I don't know why my full screen is not visible.
No, madam, it was a very great, even after the technical glitch, you managed to keep your calm and composure. If it was me, I would have got all flustered, kya karna hai, kya nahi karna hai. But you were very calm and composed, and ultimately you got
Hey,
even.
I used to present everywhere because I'm the president of Society of Fetal Medicine here. Na? So I used to present, but I know why my the upper part that was visible. So I could not.
But you did it very nicely, even though
I
so
don't
many
know because
obstacles were there. Yes, because
are
you
you
get so much scared if nothing is visible there, but you managed it. So nice.
You are, I was audible?
Yes,
Yes.
yes, sure.
My
Very
screens
nice.
were visible.
Yes,
Yes, ma'am, yes.
everything was fantastic.
The only thing is your slides were not full screen. They were not slideshow, but they were in the slide,
but we could
normal
see
slide.
everything.
But you could see everything.
It would be better if the slides were more.
No, madam,
No
the slides
problem.
were very nice. Slides were very nice. Since I am learning fetal medicine now, and I'm submitting my images to FMF UK and all that. So
I'm also, I
yeah.
am a fellow from NHM Medical College, Ahmedabad, and Prasant Acharya, sir.
Yes, madam, because I am an ART person, fetal medicine, I have to take out extra time for that. It requires lot of learning. Like the first thing I'm going to master is genetics. And genetics.
No, I think anatomy. I started reading anatomy in my fellowship. First, I've started reading anatomy. It is so difficult to remember all these things. However, I'm very, very thankful because you have chosen me to share something. I don't know whether I could have given some message or not, but as it is a PG course, so I thought it should be in a questionnaires method and case-based. So I have given this. Pragati ma'am, are you there?
We welcome Dr. Pragati ma'am, Secretary Energy Society, for a vote of thanks.
I think she has given vote of thanks.
Okay.
We just sum up. Yeah. She must have left. No problem, but it was wonderful discussion. All
Thank you,
faculties really were awesome.
Thank you so much, ma'am. Thank you.
I have 2 messages to give to postgraduate Sushma madam, with your permission.
Yes, sure.
Something which we did not do in our post-graduation is exposure to I'm not saying very high-end ultrasound machines, but at least every basic machine also has a Doppler nowadays. So every postgraduate should be taught, besides basic biometry and amniotic fluid calculation, they should be allowed to do uterine artery Dopplers, MCA Doppler, umbilical artery Doppler, calculate the ratios, know how to use the perinatology chart. So many things are free on the internet. You don't need fancy, paid your purchased apps.
And it is so
that
easy also. Easy
Yes,
also.
ma'am. And
The
they should
first
know.
step is difficult, then second step is easy. First step is to start.
Yes, ma'am. And second thing is they should know how to report, because reporting is something even I'm having difficulty sometimes. Even at this stage of my career, sometimes when I report, I feel, is my report adequate? Is my report missing something? Then whenever a fetal medicine specialist sends a report, I read very carefully, because every report I learn something. So you are very right, madam. Learning never stops. Learning never stops. And if you are inquisitive enough to learn, there is nothing which you cannot learn. So thank you, Sushma ma'am, and thank you, dear Pragati, for giving this opportunity. And thank you, Jyoti ma'am, for Jyotsna ma'am, for giving me this opportunity to listen to you. You listen to your wonderful talk. And very soon we'll be inviting you in Bhopal Obsgynae Society to deliver the same.
So thank
Okay,
you
that
all.
time I will make my
Thank you all
computers.
speakers, all
Yeah.
chairpersons, and the presenter, Dr. Vivek, and the Corona Remedies for giving the constant, very good suggestion and the very good platform for all of us. Thank you very much. And all the PG
Yes.
students also.
Just
Thank you,
I
ma'am.
just
Thank
Yeah,
you,
please, please.
just for the trial, just I have now changed my just.
Shanta Kumari, President, Foxy.
Is it visible or pura?
No,
Nahi? Is it visible now?
no.
No. Then I have to do something. Okay.
Okay.
Yes.
Okay, then. Bye.
Okay. So should we leave?
Thank you so much for joining with us, ma'am. The meeting is concluded. All of us can leave.